Hi, everybody. This is Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And I'd like to welcome you to the Journal Club. We're really very, very excited to speak today with Brian Slomowitz. And certainly this topic is one topic that we always find it's an opportunity for discussions in how to manage patients with metastatic or recurrent low-grade endometrial cancer. Before we get started, I'd like to thank ESGO, of course, and IGCS for their support in our journal club. I want to mention a few housekeeping notes relevant to the Zoom platform for today's journal club. We are recording today's discussion, and the recording will be made publicly available in our journal, and participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. And if you're having any difficulties or questions, please send a message through the chat. We always, of course, obviously welcome any questions and discussions, and we look forward to submitting your questions throughout the podcast and the Journal Club. This month's lead article, as I mentioned, is titled Evolving Treatment Paradigms in Metastatic or Recurrent Low-Grade Endometrial Cancer. When is hormonal-based therapy the preferred option, by Dr. Brian Slomowitz. Always a pleasure speaking with Brian. Tremendous amount of knowledge in endometrial cancer. So please take this opportunity to really ask this expert on your questions pertaining to recent findings in endometrial cancer. As I said, we're very, very happy to have Brian. And Brian, again, welcome. Thank you. Thank you for submitting the article to the International Journal. And Brian is going to begin with a summary of the manuscript. Brian?
Great. Pedro, thank you very much. And again, I agree. Thanks to IGCS and ESGO and the International Journal. I want to congratulate you on really having the preeminent journal in gynecologic oncology, not only demonstrated by your readership, but with the impact factor associated with your readership. So I want to congratulate you. And I'm fortunate, if you don't know, I'm fortunate enough to be one of Pedro's students when I was a fellow at MD Anderson. And we learned how I would say now we wasted our time learning how to do laparoscopic radical hysterectomies. If we could have predicted the future, we would have continued to make an incision. But Pedro, you're never wrong, except then we should have never done it. So
thank you, Brian.
Congratulations there. So what I wanted to, thanks for the opportunity to present here. I think hormonal management is something that we oftentimes forget about, and it's something that we have to consider as we move forward for the treatment of this disease. So, and it was a pleasure submitting to your journal, but also thank you for accepting it and making it the lead article. Here's the title and my co-authors. It always takes a team. It always takes a team. And the co-authors here really did a lot to help put this together and to make it a paper that it is, and to really highlight the treatment options here. Introduction. There are limited treatment options for the treatment of metastatic or recurrent endometrial cancer in the first-line setting. We know that the world is changing with immunotherapy. However, we need to consider all of our options. And hormonal therapy is definitely one of the options here, even in the first-line setting, and I'll go through some of that. And obviously in the paper that you've been able to read, there's a lot of information there as well. Endometrial cancer is turning into a disease away from the typical Bachman type 1 and type 2 that we learned about previously, but really has matured into 4 subclassifications, which are shown here. Quickly to go through them, the POLE mutations, treatment of these is simple. All right, POLE mutations do well, period. So there are ongoing studies as far as de-escalating the treatment here, but overall, when you could see the outcomes, they do really well regardless of the treatment we give. Unfortunately, they only take up about 2% of the endometrial cancer. So while they do well, it's only limited in the number of patients with this disease. And as we know, endometrial cancer is the leading gynecologic cancer that we see, at least here in the United States. And the problem is obesity, and actually it's going to overcome the number of deaths due to disease and ovarian cancer in the near future. Second classification is a mismatch repair deficient or the microsatellite unstable MSI tumors. Now, these have a lot of play in recently, particularly on that Monday afternoon in March, when Mansour Mirza and Ramez Iskander presented their data on Ruby and GY018, demonstrating hazard ratios unprecedented, 0.28 and 0.3, when combining a checkpoint inhibitor with chemotherapy in the management of mismatch repair deficient disease. So when we're talking about unmet needs, I'm excited about hormonal therapy. However, this is an area where I think checkpoints are going to take a lead role, and maybe hormonal therapy, if and hopefully not when they recur. Finally, the mismatch, the last two categories are both mismatch repair proficient or microsatellite stable. These include the P53 wild type tumors. According to the PROMISE criteria, these are no specific molecular profiling endometrial cancers, and the P53 abnormal or mutant endometrial cancers. Now, I want to really focus here on the NSMPs, because when we look at it and where hormonal management can fit in, it's these MMMPs that in the PMMR that don't respond as well to immunotherapy and are the ER positive tumors. Oftentimes, as we know, the P53 mutated tumors are ER negative, and hormonal therapy is not the first treatment for them. The last classification, and we are making universal molecular testing. We're making molecular testing more and more universal, but there are still some that are inconclusive, and we're relying on, I don't want to say historic, but previous biomarkers that we use in addition to ER testing. So there is a role in some of these tumors as well. So this is what I was sort of referring to. These are low-grade endometrioid cancers. They exhibit diverse molecular profiles, different types of mutations. The Eli, can you tell them? The NSMP tumors express estrogen receptors and or progesterone receptors. They demonstrate varied outcomes based on receptor expression levels, facilitating targeted hormonal therapies in this subtype. Wait, Eli, can you go outside and tell? Sorry, guys, I'm in a hotel and they're kicking me out. I apologize. So these are the NSMPs tumors. These are the ones that we need to really go after. Unfortunately, chemotherapy has not been beneficial in this disease. So not only is hormonal therapy non-toxic, the more toxic therapy, chemotherapy, is not as active in this disease, again, representing an unmet need. When we look at the outcome, these are overall survival data for the outcomes for NSMP tumors. The 5-year overall survival is comparable in the two groups, demonstrating that chemotherapy is not very responsive in this setting. Again, demonstrating an unmet need here. And I apologize for the background noise. It's going to go away right now. Again, so this is one of really the key driving pathway that we often see in these tumors. And when we talk about driving pathway, we sort of another way of highlighting these is if there are available drugs, this is where the targetable mutations lie. So obviously we don't have targetable drugs and targetable mutations. Obviously we don't have drugs for all these pathways, but real quickly going through them, obviously upper left, we have some estrogen receptors that can be blocked. Moving down, one of the areas that I focused on and we'll talk more about is the mTOR pathway, leading to overexpression of S6 kinase and 4-EP binding protein. This pathway can be blocked, and it's been found to be effective. We have ongoing trials in blocking the AKT pathway, as well as MEK inhibitors and moving into the nucleus, CDK4/6 inhibitors. All of these can help to promote decreased cell proliferation. Really, they're cytostatic, so not having the tumors not grow and prolonging progression-free survival. One of the things to highlight here, and this is really important, when we look at estrogen receptor and its effect on the cells, there are two pathways: the cytoplasmic pathway, as demonstrated on the left, and the direct nuclear pathway on the right. So it's these two pathways that are driving the growth and proliferation of estrogen, not just in the nucleus as we originally sort of thought about. There is crosstalk, obviously, between these growth signaling pathways and the estrogen receptors. And as alluded to, the estrogen receptor signaling has multiple regulatory pathways within the cell. Now, Pedro, one of the areas that I've really been focusing on in my career started at MD Anderson, where I started to look at mTOR inhibitors in the management of this disease. The first one we looked at was everolimus. Everolimus is an oral mTOR inhibitor when I was a fellow, actually, we did a single-arm trial in endometrial cancer. We found a stable disease rate of about 28%, but we didn't see the kill. We didn't see the cytotoxic effect that we saw. Two other studies brought us to NCCN listing, combining everolimus and letrozole. The rationale here is we're getting the activity that letrozole, the aromatase inhibitor, we're getting the activity of the everolimus in the pathway showed on the left. But more importantly, we're seeing helping overcome hormonal resistance, the interaction of everolimus, the estrogen receptor, using letrozole. In our study, GOG-3007, we looked at both chemo-naive and chemo-pretreated patients treated with everolimus letrozole. And we demonstrated a 28-month progression-free survival, 28 months. Comparing the cross-trial comparison, which we never can do, but we do anyway, GOG-209 had a progression-free survival in chemo-untreated patients of 14 months. Really remarkable, really something that our patients can help benefit from, demonstrating this longer progression-free survival. Again, a cytotoxic effect. So you can't look at response rates. You have to look at progression-free survival. 28 months, while patients receiving prior chemotherapy in my study, 4 months, but again, chemo-naive patients, 14 months. Another pathway that we're overly excited about that has some preliminary data, really, as looking at the CDK4/6 inhibitors, as you can see in the nuclear pathway, with letrozole, showing a clinically meaningful progression-free survival in advanced or recurrent endometrial cancer. The best trial here was the Paleo trial, led by one of our co-authors, Mansoor Mirza, looking at the CDK4/6 inhibitor plus letrozole versus letrozole alone. Progression-free survival was about 8 months versus 4 months. So let's dive into it a little bit. Let's talk about some of the highlights of the study. I really want to highlight here, because the most important part of this session is really going to be our discussion. Here's the study, talked about the introduction, talked about hormonal therapy with biomarker-driven therapies. On the bottom left is the pathway we talked about. Again, the majority of these tumors are NSMPs. Here I want to take a moment. I don't have this slide, but if we look at the Ruby data, if we look at the different responses to checkpoint inhibitors, again, the poly mutations don't need anything. The DMMR patients, checkpoint alone. We're actually doing 2 trials in that setting, looking at checkpoint alone without chemotherapy. A trial that I'm leading, GOG-3064 or Keynote C93, and a Dominica trial led through Europe looking at dostarlimab in the same setting. Again, so review. P50, poly doesn't need anything. DMMR checkpoints. Surprisingly, the PMMR P53 mutated patients, these are the uterine serous and the carcinosarcs, they did actually pretty well adding checkpoints. There's a separation of the curves. It followed that thumb rule that if you could stick your thumb between the 2 lines on the Kaplan-Meier curve, there was a benefit, and there was. Just as surprising, in the NSMP tumors, we did not see that benefit of immunotherapy. Again, representing an unmet need, representing an area of opportunity. Hormonal therapy, again, it's not only one answer. We also were looking at selinexor, a nuclear transport inhibitor, and an MDM2 receptor inhibitor that are 2 ongoing trials. But it's a hormonal pathway here that we're really excited about. Talked about the crosstalk between the PI3 kinase, AKT, and mTOR inhibitor. Stephanie Gayard's leading a nice trial looking at a blockade of AKT with letrozole that we're accruing to. And actually, the results with chemotherapy-naive patients is really unprecedented. Conclusions of our paper: chemotherapy has higher objective response rates, but we need to do better. But we have a longer PFS with the hormonal-based therapies. And we need to use the information we see in the molecular subclassifications to help us drive therapies moving forward. Pedro, really excited about this work. I know a lot of this is really going to focus on our discussion. So again, thank you for the opportunity. And I really appreciate talking to our team internationally to discuss this further in your journal club setting. Thank you.
Well, thank you so much, Brian, for your time, for your explanation. And again, I mean, I think that this is a great opportunity for everyone to really hone in and discuss really the entire scope of treatment options for patients with endometrial cancer, given Brian's expertise. We're going to start with the first question from our fellows, and I think the first question is going to come from Giuseppe Caruso, and he's going to talk about the options of hormonal therapy. So, Giuseppe, why don't you go ahead and ask the first question?
Yeah, good morning, everyone. Thank you, Dr. Slomovitz, for this great article and the presentation. My question is, endocrine therapy has several options, including progestins, aromatase inhibitors, and fulvestrant. And we also have several combinations. So is there a preference or can we use any criteria for their sequential use? And also, can we re-challenge hormone combination treatment like we do in hormone-dependent breast cancer?
Yeah, so thank you for that. That's a lot of information there. So if I missed something, you'll get back to me in the end. So one of the questions I heard you say is sequential management. Now, the answer is, number one, there's no prospective studies on that. But we're in the trenches. We're treating patients. Oftentimes, patients come to me as a second opinion that are on hormonal-based therapies. It's in these settings that if they're starting to grow disease slowly, and then I look for opportunities there. And one of the opportunities then is to either change the hormonal-based therapy and add a biomarker, and I'll touch on that a little bit, or just to add a biomarker-based therapy in mTOR or CDK4/6 in that setting. A couple of take-home points here. Low-grade endometrioid tumors usually have a slow indolent course. They're not as rapidly dividing as the P53 mutated patients. So in saying that, stable disease is pretty good in these patients. Slow indolent, you're adding something to help stop the growth. Oftentimes I give my patients this question. If you could live forever with a disease that you have, taking some oral drugs, would you do it? A lot of some patients are overly symptomatic and they need more, but most of my patients say, "Doc, give it to me. I would love to live 20 years just like this." And we're able to get that. I'm not sure about 20 years, but we're able to get a prolonged, durable response. The other thing, and I just alluded to this, and you have to be careful, combining these agents sometimes lead to excessive toxicity. There was a study, GOG-248, which had progestin-based therapy with an mTOR inhibitor. The study was stopped because progestins have an increased risk of thromboembolic events. So, for example, if I have a patient on progestins, which is starting not to work, I'll then switch over to an mTOR inhibitor with aromatase inhibition because I don't want them to get blood clots. That was a long way of answering your question, but in summary, we're not going to have the data, but in the real world setting, in the trenches, I definitely do that. Now, can you remind me, what was the second part of that question?
Yeah, I was asking if there's room for a re-challenge for hormone combination as we do in breast cancer, but I think you touched it also.
No, but just to add a little bit, now the mTOR, in GYN oncology, and this is sort of my little secret, we don't have to recreate the wheel. We have to borrow from what we learned in other diseases. So a low-grade endometrioid cancer is a lot like estrogen receptor breast cancer. There was a study called the Bolero trial, which led to an mTOR FDA approval of everolimus in breast cancer. A lot of those patients did have previous aromatase inhibition. They were retreated with an aromatase inhibitor, however, a different one. Diving into it a little bit more, there's steroidal and non-steroidal aromatase inhibitors. That trial changed from a steroidal, either an Arimidex or letrozole, to a non-steroidal exemestane with mTOR, and they did see the benefit. So yes, there is a role of changing the hormonal therapy and re-challenging with the same class, albeit a bit different.
Okay,
excellent.
Thanks.
Very, very well, Brian. Thank you for that answer. And then certainly we encourage those of you who are tuning in to send in your questions as well. Next, I think is Jorge Hegel from Venezuela, and he wants to talk to you, I think, about a topic that you know very, very well. Jorge, you want to proceed with your question?
Yeah, thank you, Dr. Ramirez, and thank you, Dr. Slomovitz. My question is, your group published wonderful results with the combination of everolimus and letrozole. Do you, in any circumstances, add metformin?
That's a great question.
Adding metformin, yes.
Metformin. Now, let's take the disease in general. This is a disease of obesity, which I mentioned briefly earlier. A disease of obesity oftentimes is associated with not only diabetes, but insulin resistance. So in our studies, we actually found a lot of people were already on metformin. So whether that contributed to the effect or not, I'm not sure. We actually weren't able to do that. There weren't enough patients to do a sub-analysis there. But we do feel that it may have played a role there. Now, two things. But remember, there was a study by Vicky Bajemp at University of North Carolina, which looked at chemotherapy plus metformin in the first-line metastatic disease, and it was a negative trial. So it wasn't enough there to prove it in that setting. However, Pam Solomon did an open-labeled one-arm trial at MD Anderson, everolimus letrozole with metformin, and cross-trial comparison. I'll say it again, you can't do that, but we do anyway. Didn't seem like it added a lot of benefit there. So adding it didn't do anything, but a lot of patients are already on it.
Very well. So when the patients are on it, you certainly are not taking them off of it, and you just continue with the metformin.
Correct.
Excellent. Very well. I think that this next question was from Jessica Mauro, but she hasn't been, it's not going to be able to join us. So is Jorge going to ask the next question?
Yeah, for sure. The question is, now that Ruby shows NSMP is not that susceptible to chemotherapy with dostarlimab, what is your treatment of choice after hormone combination treatment?
Yeah, so let me clarify a little bit. Chemotherapy was beneficial, but the addition of checkpoint inhibitors did not increase the effect of chemotherapy. But you're right, it's beneficial, but it's also not as good as it is in other subclassifications. So NSMP tumors, P53 wild type, what are our options? Hormonal therapy, to your point. Still chemotherapy. I would not eliminate from that. However, one of the things that I would consider is not adding the checkpoint to the chemotherapy. And as I alluded to, we have two really compelling ongoing trials. One of them has really strong previous data. The SIENDO trial was previously done looking at selinexor, a nuclear transport inhibitor, versus placebo in all comers. What we found in all comers, it was a negative trial. However, in the subgroup of patients with P53 mutated tumors, extreme benefit of selinexor. And then not only that, this past summer, we presented a long-term follow-up. PFS difference in the P53 wild-type tumors, 27 months versus 5 months. 27 versus 5 with a hazard ratio approaching and 0.3 or 0.4, I forget exactly, but we went to the FDA. We said, hey, guys, you got to approve this. This is insane. It is great. Unfortunately, it wasn't a primary objective of the study. FDA said, you're right. It's great data. Go out and do a separate randomized phase 3 trial confirming this. And we'll listen to you again. I can't predict approval, but we'll listen to you again. There goes the ongoing trial, which is open at Dr. Ramirez's site as well. The export trial, which is randomized phase 3 trial of selinexor maintenance in the P53 wild type patients, where we saw that difference. So that's another option in that setting as well.
Remember, again, as Brian was mentioning, is in the P53 wild type where the benefit may be for selinexor. So that's we're definitely looking forward to those results as well. Brian, I'll interject. I mean, since we are now on the topic of the Ruby trial using dostarlimab in patients with advanced or recurrent endometrial cancer today, based on Ruby trial versus the NRG trial, looking at with pembrolizumab, what is your choice these days for treatment in this setting?
Great question. So let me start off. Number one, on October 30th, there was a press release saying that in all comers, there's an overall survival benefit of chemotherapy plus dostarlimab. Okay, overall survival benefit, unprecedented. We haven't seen that. Then you say, well, we're waiting for to see the same thing in pembrolizumab. It's never going to happen. When pembrolizumab met its primary endpoint of PFS, the company decided to stop the trial and to make sure everyone got pembrolizumab. So we're not going to see overall survival data from GY018. However, we could borrow from it. But that wasn't the question. The question here is, what do I do? I think that it's always nice to have two drugs available. So to be honest with you, in my clinical practice, I use both. Here in the United States, a lot of our decision-making is based on payers. So insurance companies may have a relationship with one drug or the other drug. And I've done this before. I've written for, I won't tell you which one, but I've written for one, either pembro or dostarlimab. The insurance company said, great, we're going to give you pay for this one. You don't have a choice because it's cheaper for them. But I think that's okay. You know, we're saving a couple of healthcare bucks, and if we could save a couple bucks in the system, that's okay too. So I use both, and obviously I'm a little bit more familiar with pembrolizumab, but I still use both, and I still think that both studies are important and both studies are practice changing. And as a reminder, at ESMO this year there was a third study, the ATTEND trial, chemotherapy plus minus atezolizumab. And I'll talk about this in one other study. Now, the atezolizumab, a little bit different pathway. It's not a PD-1, it's a PD-L1. Also a positive trial. Not FDA approved, not on NCCN here in the United States, but I anticipate it will be sometime in the near future. Last but certainly not least is the DUO-E trial, which not only confirmed the advantage of checkpoint inhibition in addition to chemotherapy, but it looked at another drug, PARP inhibitors, with checkpoints with carboplatin and paclitaxel, and they saw a benefit of that combination, suggesting that PARP inhibitors may play a role in this setting as well.
Excellent, very well. And Brian, the next question is from Guido Balsaki, and I think certainly relates as to when to use the endocrine therapy. Guido.
Thank you, Dr. Slomovitz. Yeah, my question is that since it appears that the benefit of endocrine therapy is higher in chemotherapy naive settings, should we prefer endocrine therapy over chemotherapy as first-line treatment?
That's a great question. Short answer is yes. The other answer I want to give you is in the Ruby and the GY018 trial. Now listen to this, right? They didn't count hormonal therapy as a line of therapy. Those are both first-line trials, and they allowed prior hormonal therapy and still called it a first-line trial. So the answer is yes, I would use it as first-line study or pre-first line if you want to listen to those trials. That most definitely. Does that answer your question?
Yes, thank you.
And Guido, I think that you can ask the question by Giuseppe Cucinella. You can go ahead and proceed.
Okay, yes. His question was that Dr. Slomovitz, you have previously shown that the everolimus in combination with letrozole results in a high clinical benefit in patients with recurrent endometrial cancer. Do you see a potential use of this combination in the case of non-surgical candidates, endometrial cancer patients, like for fertility preservation or due to comorbidities?
Oh, yeah, most definitely. That's a great question. I think that and Pedro, you may remember this more, an IUD with everolimus. That was a study, a really hypothesis generating study at MD Anderson, which I did believe showed benefit. I'm not sure if there was how they assessed the contribution of everolimus, but I think there's a role there for fertility preservation. And alluding to the neoadjuvant setting for patients with widespread disease, I would consider that as well. Sometimes neoadjuvant, you want more of a kill. You want to be able to surgically debulk these patients. So if you want the kill, if you want the shrinkage, again, I maybe would consider, in my practice, I may give chemotherapy first in order to shrink the tumors, in order to give some cytotoxic debulking. So what did I just say? We're not going to eliminate chemotherapy completely. So it's still worthwhile in some settings.
Excellent. Before we go to Matt, there's a couple of questions from the audience. And Brian, the first one is, given that these tumors are relatively slow growing compared to P53 tumors, how frequently would you do imaging studies when patients are on hormonal therapy?
Yeah, that's a great question. Again, a lot of these tumors aren't going to shrink. Some of them may grow a little bit and then shrink or sort of become stable. I'm going to repeat imaging maybe after, just like we do, maybe after 3 cycles. But if I do that once or twice and it's completely stable, I'll go based on clinical disease, shortness of breath, pain, things like that. Because a lot of these patients, I think it's good to have a number and a measurement on a CAT scan, but ultimately we want to look at the patient. That's the best predictor of response. Patient's doing well, they're thriving, productive lifestyle, eating, not losing weight. I don't want to have a rule say 8 weeks or longer. I would reserve imaging a little bit. So, and another point on that, that's a great, and as far as imaging modality, I would not do a PET scan on these patients. Remember, PET scans are looking at metabolically active cells. Given the fact that these are slower indolent course, I would rely more on thin cut CT scans for the observation here.
Fantastic. Brian, we have a high level of attendance, lots of questions. And actually, I see Anna Plotkin, who is raising her hand. Anna, you can proceed and ask your question directly. And thank you for joining us as well.
Thank you, Brian. Great presentation. Quick maybe note and question to you. An SMP group is actually quite heterogeneous group in general. There are clear cell carcinomas there. We learned that some of the low-grade endometrioid carcinomas are now ER-negative carcinomas. There is also mesonephric-like type and gastric type that also part of an SMP group. P53 is generally we do for most of the cancers and that part of that pathway that you mentioned, but ER is not. So someone, let's say, saying low-grade endometrioid carcinoma, in fact, it might be something different, and we don't require people to do ER upfront. What is your approach, and what do you do at your institution?
Yeah, great question. So first of all, ER positive testing is still part of my routine universal testing on all my patients. What I suggest for your team, for everyone here, is sit down with your pathologist, and you don't want to order it for every case. Make it universal testing. Just like they're doing histological evaluation, you want ER, PR, you want DMMR, PMMR, MSI testing, and then people say to me, well, why am I going to do that on a patient with a minimally invasive grade 1A tumors? Don't forget, MMR testing is also evaluating for Lynch syndrome. So not only are you going to get the help with therapeutic decisions, but you want to assess whether or not the patients have Lynch with a germline mutation. And then there is this study that was out that's been out looking at the division of the NSMP tumors, estrogen receptor positive versus estrogen receptor negative. And I think you're alluding to that. And in that study, I would take it a step further. Yes, I would divide these tumors ER positive, ER negative. The ER negative tumors do much worse. And those tumors, I would likely not do hormonal therapy and go to the routine therapy. But the ER positive tumors, and as you're alluding to, let's put them on hormones. Let's see what we get out of it. And I think you'll see a benefit there.
Yeah, that was my comments for your audience. So because I see a lot of young faces, just be in contact with your pathologist and think progressively and ask for. I'm sure it might be you have a limited resources, but they are pretty much is available everywhere. So please do ask for the stain.
Yeah.
Great. Thank you so much, Anna, for that question and for joining the Journal Club once again. Now we'll go next to Matt Wager from one of the coldest places in the United States, Wisconsin. Matt.
Hi, Dr. Slomovitz. Thank you so much for your presentation. Along the lines of what Guido had asked earlier, several of the studies that were highlighted note a greater efficacy of hormonal therapy when used prior to other systemic therapies. So what I'm curious about is what data do you think we need in regards to hormonal therapy and molecular classification to move hormonal therapy to the front line or the maintenance setting?
Yeah, that's a great question, and it's been very difficult. I can tell you within the GOG in our partnership with NGOT, we've been evaluating 3 or 4 CDK4/6 AI aromatase inhibitor studies to be done in the first line setting, and I can tell you right now we're 0 for 3. Not because of a lack of interest, but lack of pharmaceutical support, which is something that we need to. We're still pushing, and I could say without divulging confidential information, there's still a chance that we're going to move forward on one. So it needs to be pushed in the first line setting. It does. As far as maintenance therapy, these studies that I'm talking about do have prolonged letrozole use. As you know, we use AIs in breast cancer for a longer period of time. That's my academic answer. In the trenches, this is my opinion, isolated from any, this is my opinion. I use aromatase inhibitors all the time for my deeply invasive endometrial cancers to prevent it from coming back. Not only that, I'm decreasing the risk of breast cancer as a preventative measure. That's not what I'm thinking of. That's not my first thought. And Pedro's laughing because we always think outside the box. We're always thinking, we're just thinking, what can we do outside the rules? But if someone wants an argument to tell me I'm doing harm, I'm happy to make that discussion. But I think I'm doing something good for the patients. And if they have muscle aches, worsening menopausal symptoms like that, the first thing I'll do is a side effect profile in AIs is not the same. Unlike other drugs in the same class, I'll switch from letrozole to Arimidex or Arimidex to letrozole, and I see it decrease in the side effects. But then if they persist side effects, I don't have enough scientific data to push them. I'll just take them off.
Okay, very well. And actually, you mentioned breast cancer. This brings us to our next question from Turkey, Sida Sahin Akar.
Thank you, Dr. Slomovitz. My question is, if a patient has concurrent hormone-negative breast cancer and recurrent low-grade endometrium cancer, what is the optimal treatment or hormonal therapy?
Yes, that's a great question. So if they have two cancers, was a hormonal therapy? Yes. Put them on aromatase inhibitor. Again, I'm not a big fan of progestins because of the thromboembolic events, and that's sort of a game over situation, right? So I would put them on aromatase inhibitors. And in patients with a history of clots, you can give letrozole. People are worried about that. You can. It doesn't cause clots. Other options, fulvestrant is an option in those patients. Tamoxifen. New class of drugs coming out. Giredestrant is one of them. It's a SERD, another degrader of estrogen, which is the next generation. That I'm doing a proof of concept study with Genentech of giredestrant in newly diagnosed patients with grade 1 endometrial cancers. We're treating them for 6 months after their biopsy, and then we're doing a hysterectomy or DNC, and we want to see if it works in that setting. And I think it'll be a positive study, but I think it'll be a compelling enough study to do further investigation in that setting.
Great. And next question is from Luigi Davitis. I think he's back from the OR. So Luigi, please proceed.
Thank you, Dr. Slomovitz. In the manuscript, you mentioned several exciting studies investigating the combination of hormonal therapy and other targeted therapies. So I would like to know, in your opinion, what are the most promising targeted therapies in low-grade endometrial cancers?
The most promising, I think, the mTOR inhibitors. Now, it's interesting. We try to progress mTOR inhibitors into a first-line trial. One of the competing factors here is pharmaceutical companies have to think of the life of the drug and how long they're going to make money on it. It's a cost of doing business. That being said, there's a newer drug out there, a nab-sirolimus, by a company called AADI that has been FDA approved in PCOMAs, that has some preliminary data in endometrial cancer, and it's worthwhile pursuing it further. I could say that, use your imagination what I mean by that, but I don't want to divulge anything else. But we're excited about that. CDK4/6 inhibitors, I think, are exciting as well. So between the nab-sirolimus, the old everolimus, and the CDK4/6 inhibitors, I think there's a bright future here. And the AKT inhibitors that, as I mentioned, Stephanie Gayard's looking at.
Excellent. Very well. And Ryan, and before we come to a close, there's another question from the audience. This one particularly about a patient. This patient has grade 2 endometrioid type without any myometrial invasion, without lymphovascular space invasion. She's P53 wild type, poly negative, ER positive, and 1 millimeter micrometastases in a single sentinel lymph nodes. Would you give her hormonal therapy? So grade 2, no invasion, no LVSI, P53 wild type, ER positive with a micromet on a lymph node.
Yeah, so have I done that? Yes. Will I do it again? Yes. Do I think it's the best treatment? Yes. That being said, we have to give patients the current recommendations and talk to them about it. So it's a little bit longer of a conversation with patients. I'm clear. I say the best data that's out there based on prospective studies is to give chemotherapy in the setting of lymph node positive disease. I don't want to talk too much about is a 1 millimeter focus in a sentinel node, is that really positive or not? I think that's outside of the scope of this talk, and that'll take us about 4 or 5 hours. And I wouldn't even be invited to that talk. That would be Mariani, that'd be Pedro, that would be Lateo, that would be Abu Nadim. But I treat it as positive. I would, and that's just the way, if it's there, it's there. The no LVSI is wrong. The pathologist didn't look closely enough because it's in a lymph node. It was in the lymphatic space. First recommendation is hormonal therapy versus chemo. Yes, I could use one or the other. I wouldn't do both. It's based on GOG 249, showed not, they're pretty much the same outcomes. But if a patient says, well, I'm not, as soon as they say something hesitant, I say, all right, let's go to hormonal therapy, everolimus letrozole. And I think that's a reasonable option there. Again, that's a Slomovitz opinion, not the current guidelines.
Well, Brian, thank you so much. And thank you again for the disclaimer of the Slomovitz opinion versus the NCCN guidelines. Always appreciate your honest clinical input. Again, thank you once again for submitting the manuscript, for the work that was put into this manuscript, for answering all of these really great questions. Thank you to the fellows for submitting those fantastic questions as well. Certainly, as I mentioned, the recording of today's session will be available in the journal, the IGCS, also the ESGO website. And I want to invite everybody to the Journal Club in December, where we will have Reitan Ribeiro talking about uterine transposition. So thank you all so much. And Brian, once again.
Pedro, one comment here. I know we have maybe 2 minutes, but the last question is, if positive sentinel node does not have LVSI, that is not a wrong pathology report. As we know, LVSI predicts lymph node involvement, right? So it predicts it. It's by itself is a predictor. So if there's lymph node involvement, there's lymph node involvement. I'm sorry for that interruption.
It's okay. It was a last minute question. So thank you for providing that input. And, certainly I'm sure you will be welcoming any additional questions that any of our viewers might have. And once again, thank you, Brian, and thank you all for joining.
Thanks, Pedro. It's a pleasure. It's really a lot of fun. And congratulations again on all of your great work.
Thank you.